alloplastic bone grafting materials and how we can use them in contemporary oral surgery and implantology. It's not about orthodontics, but I think that many colleagues will find such topics very interesting. And also, I believe we can apply such topics also in orthographic surgery. So that's me. I have a master and a PhD in oral surgery from the University of Athens. The last 7 years, I live and I practice in London, in the UK. I travel all around the world to give lectures, and with Dr. Algamti and other excellent colleagues around the world, we are very happy to do constant top-level research. All this is focused on novel synthetic bone grafting materials. And that's what I will try to share with you today. We try, of course, to publish our findings. It's not easy, but we try hard. The last 15 years, we have managed to do more than 25 publications in PubMed journals. And you can find them online, or I can share with you all the PDFs for the publications. And mostly everything is about bone grafting, about how we can regenerate high quality new bone. And what we try to do is we try to use synthetic alloplastic bone grafting materials. And I will explain to you our rationale and what we think, how they work, and why we believe that maybe it's the future of bone regeneration. So when we want to do bone grafting, where we want to reconstruct the bone, we have to find out what we are doing and what are the parameters for bone grafting success, which of course, it's not an easy question. We have many questions. We cannot give all the answers. And to try to identify the ideal bone grafting material, we have to break down this question and to see which are the elements that contribute to success, to failure, what are the indications, the limitations of any different bone grafting material we are using. Definitely, everything lies in the basics, and the basics, of course, of surgery and bone biology. Always we have to focus on the basic principles when we are dealing with bone grafting materials, with bone augmentation. Why we are using such materials? We are using them every day to reconstruct the bone, to create new bone, to do some kind of augmentation, because we know that implant dentistry is a prosthetically driven science. So we need to place our implants not where we have bone, but at the ideal prosthetically driven positions. So many times, every day, we need to augment the bone in order to build those foundations. Or in other cases, in everyday dentistry, like after extractions, we use bone grafting materials for preservation because we want to limit the resorption and we want to create fast new bone to place our implants. What we are doing every day, we select the bone grafting material, we fill our defect, then we close the surgical field. And if everything works well, like in this case, we have a good clinical outcome. And if we take our X-rays and we re-enter the area after 3-4 months, then if everything goes well and we have done our work in a very nice way, we have created good hard tissue to place our implant in a very good 3D prosthetically driven positioning. So that's what we are doing every day. But we have to focus on what tissue we are reconstructing. And for us, like scientists, we are not just, it's not enough for us just to use any material, whatever, let's say, any distributor sells to us, but we have to be aware and we have to understand that each material is working in a totally different way. And for me, this is the most important take-home message, is that first of all, when we start doing surgery, when we start doing implantology, we need to understand the essential, which is that there are big differences. There are big differences between the different bone grafting substitutes, and they have different resorption rates. And that means that they have different new bone formation capabilities. So for this reason, they work in a different way. And for this reason, they have different indications and different advantages and disadvantages. But definitely, we have to understand what we are doing, what materials we are using. It's always the same. If I use the wrong bicycle, and let's say I take the bicycle of my daughter to go up the mountain to cycle, the bicycle will break. So it's not the problem of the bicycle, it's the problem of my choice, my selection. The same applies in dentistry. And after many years, I try to make things simple in my mind. We need to know that these are the basic categories. We have xenografts, we have synthetics, alloplasts, and we have allographic human origin bone substitutes. The big difference is that some of them are resorbable and some of them do not resorb in the site where we implant them. In general, we have the xenografts, and in general, the xenografts are very slowly resorbable or they don't resorb almost at all. On the other hand, I prefer to use materials that they will fully turn over into bone, and these materials are the human allografts. And what I'm using is I'm using synthetics. So I'm using beta-tricalcium phosphate, calcium sulfate, and some mixtures with silicate. These are the properties of the ideal bone grafting material. This is from a very nice paper from the team of Lang when he still was in Hong Kong University. And in the introduction, they very nicely describe the properties of the best bone grafting substitute, theoretically, of course. And these are all the important properties. It has to be inductive, conductive, biocompatible. We see that the ideal material must totally be replaced by bone, at the same time to have an appropriate resorption time in relation to bone formation. Of course, we need to maintain the volume, good mechanical properties, and last but not least, we have to be aware of any risk of disease transmission. We like synthetics. We believe that synthetics, the alloplastic substitutes, are the future in bone regeneration. That is what is happening nowadays in orthopedics and in bone science. One big advantage with synthetics is that all the patients like them. It's very easy for the patient when we do our consultation to accept to have a synthetic for his bone grafting, for the patient bone grafting, because first of all, there is no risk at all for any disease transmission, and we have no problems at all with any social concerns or religious concerns. So first of all, synthetics are an excellent choice for communicating with the patient and the patient to accept this kind of materials. But for us, the big benefit is that the fully resorbable calcium phosphates, those synthetics, they produce a very high quality of new bone, and this is very important in oral surgery, and especially when we place implants. And because we can mix the beta-tricalcium phosphate with other components like calcium sulfate or PLGA or silicate, this can give us very good handling properties. It can give us also stability of the graft, which is a very important factor for bone grafting success. And at the same time, as you will see, we can have minimally invasive procedures, less steps, and make our work much easier, which also is a big benefit for the patient. I'm going to show to you what we have learned the last 15, 20 years working with resorbable synthetic materials composed of beta-tricalcium phosphate, calcium sulfate, and silicate mostly. And at the first part, I will share with you some findings from preclinical animal studies that we have done and we have published the last years. And I'll show you some interesting findings. This is a paper that we published a couple of years ago. We used, as you can see on this video, we used rabbits, and one very good surgical model using the rabbits is to go to the head of the rabbit to open the calvaria, as you can see here that we do our incisions, and we create standardized bone defects on the calvaria of the rabbit. So you can see here how we section the periosteum. Here we elevate the periosteum, and you can see this membrane, the periosteum. You can see all the blood vessels, and this is the best membrane we can have to regenerate bone. In my daily practice, I try to avoid using any barrier membranes in cases where I have small defects. In cases where I have graft stability, I never use a barrier membrane. I use the periosteum, which is for me the best membrane we can have from nature. Now that we have elevated the periosteum and we have opened our surgical site, using trefines, we create standardized circular bicortical bone defects. As you can see here, we remove, after using the trefine, this bicortical bone, and we have very nice circular, standardized in shape and dimensions defects. Here we use beta TCP with calcium sulfate. So this is a 100% synthetic resorbable material, and you see that it's like a paste that when we place it inside, it starts getting hard. Now you can see the clinical difference when we are using a common particulate xenograft. So you see how differently it handles, how different is the composition and the structure of the material. So it's a loose granulate that we just have to pack it so it doesn't get any self-hardening stability because it's different chemical composition. So during the surgery and during our everyday practice, we see that the materials are different regarding the different origin and chemical composition. Now, the big difference is how they heal. So this is after around 8 weeks, 10 weeks. So you see the difference regarding the healing macroscopically. This is a site that was healed spontaneously. So we have a thin layer of autogenous bone. And look the difference when we have used a xenograft, a particulate xenograft. It's a totally different healing pattern. When we are using the synthetic, this is ethos, beta TCP with calcium sulfate, we see that we have a different healing pattern macroscopically. It looks more like a natural healing pattern. And this synthetic material can give us a better quality of bone. And first of all, macroscopically, we identify the differences. And after observing macroscopically the differences, then we go and we have other ways to do our measurements and to do our observations. We can do micro CT, and then we can do different analytical methods, and we can measure. So we find what we find in all the other published studies, that the synthetic here, ethos, beta TCP with calcium sulfate, gave us more bone than the xenograft and than the spontaneous healing. So in many cases, the synthetic can promote and enhance the bone regeneration. At the same time, we find something that it's logical and we expected it. The synthetic had less residual material than the xenograft, because the xenograft is not resorbing, or it's very slowly resorbing. And that's why sometimes it keeps the volume better than synthetics. Also, it's very important that the novel new synthetic absorbable materials are not only osteoconductive, but they are also osteoinductive. And this is a very interesting and very good property of those materials, because it means that beta-3 calcium phosphate and silicate, when we place them into the bone, they are also active materials. That means that they not only serve as a three-dimensional scaffold, but also they are able to promote osteoinduction, meaning that they can recruit stem cells and transform those stem cells into bone-forming cells. This is important. This is important because with also osteoinduction, we get even better quality of bone and we get faster, more bone. If we want to prove that a material is inductive in science, the only way is to do, again, animal studies, and we need this time to place the material not into a bone defect, but the opposite. We have to take the material and place the material in an area where there is no bone at all. So we place the material or under the skin, or we place the material even better inside the muscle. So in this kind of experiments we have done, we open the muscle and we place the calcium phosphate material into the muscle. What happens is that if the material, like in this case, is creating osteoid, so we can see here that there are some areas of newly formed osteoid tissue, it means that the material into the muscle was inductive, so it gave the signal to stem cells from the blood to create bone. The opposite, when we're using materials like xenografts that are not osteoinductive, they are only conductive, we don't find any bone at all. So this is the histology on the left side when we placed into the muscle a xenograft, and we had only the particles of the material surrounded by muscle, bone, and connective tissue. The opposite, when we placed the calcium phosphate, we had the remnants of the material, we had some muscle, but we can see also that inside the connective tissue and in contact to the particles of the synthetic, we have osteoid. So we prove, like other experiments that we can find in the international literature, that novel beta-3 calcium phosphate synthetics are also osteoinductive. And this is a very good and important property. Now we need all those findings, all this knowledge to transfer it to our everyday clinical practice. So we try to do what's the best we can do with those materials in our oral surgery and implant cases. We have published many papers, and also with our human cases, we do for studies histology and micro-CT measurements. So what we are doing is we need to take a trefine biopsy after we have done some kind of bone grafting for our patients, for our clinical studies. One very good way to see the healing of the bone grafting material is to take a trefine biopsy. As you can see here, this is the trefine that we harvested the regenerated bone from our patient. This is how it looks inside the trefine. And then we place this new bone into the scanner, and we can have a three-dimensional micro-CT analysis. With this micro-CT analysis, we can measure the whole specimen, the whole volume of the specimen, and we can have measurements regarding the density of the hard tissue, how much bone we have, how much new bone, and what's the volume of the residual bone grafting material. And the benefit is that we measure those elements in all the area of the harvested specimen. And this is important clinically. It's very important because in this kind of tissue, we are going to place our implant. So if we had a magical kind of vision when we do our surgery, we could identify that this is how the reconstructed bone in the mandible or the maxilla of our patient looks when we have used a bone grafting material to regenerate the bone. So we have new bone that looks like trabecular bone. It looks like a sponge, as we can see here. We have remnants of the material, and in this tissue, we're going to install our implant. This is important, and there are very nice papers to read about this, because there are concerns about what's happening if we have a large amount of remnant non-resorbable material in this tissue very close to the threads and the surface of our implant. Because what we need to do is we need to create high quality bone, because we need osseointegration, meaning that we need the titanium implant surface to get in contact, in full contact, into biomechanical contact with living high-quality bone. So that will give us the highest amount of bone-to-implant contacts. And the better the quality of the regenerated bone, the better the biomechanical properties and the long-term stability of this bone. What we mean when we say the quality of the regenerated bone. Let's see this micro-CT. This is a micro-CT from a site where we used a totally absorbable synthetic material. And as you can see, we created a tissue that looks like vital, pristine bone. It is absolutely a trabecular regenerated bone. In this tissue, we are going to place our implant. So if I go to my 3D scanner, my micro-CT scanner, and I scan this from top to bottom, so this is the axial view, and we go from the cervical to the apical part, we can see that in all the volume, my implant, if it's placed in this tissue, will be surrounded by good architecture, good quality, and good volume of trabecular newly formed bone. So we see that the new tissue has all the radiological appearance and characteristics of high quality normal trabecular bone. This is where ideally I want to place my implant. Now we have to understand the big difference. When we are using xenografts and when we are using materials that are not resorbing or they have a very slow resorption rate, it means that around 30 to 40% of the volume of the particles will stay there for a very, very, very long time. That will have a very big impact to the quality and the architecture of the new hard tissue. So if you see the results here of my studies, and if you can see all the papers that have micro-CT findings from studies using bovine xenografts, you will see exactly the same appearance, the same picture. So in 3D, radiologically, the new hard tissue, when we use xenografts, it looks like that because it has too much bovine xenograft. Now, if we go and we do the same and we scan it in 3D, you can see that the whole volume of the bone of the reconstructed hard tissue is totally different. It has too much bovine xenograft, which is embedded into new bone, and this has a very big effect on the architecture and the quality of the new bone. It's important, it is essential, because we are talking about orthopedics, placing an implant into hard tissue. It's an orthopedic procedure, so we need to have the highest quality of bone. The message is that if we use synthetics which are resorbable, most of the times, if the healing goes well, we will get high quality bone that looks like normal trabecular bone. If we use a particulate xenograft to keep the volume in a very nice way, we have to understand that the quality of the bone will be much, much worse. And it is important because this new bone around the implant, especially when we're going to load the implant, will need to remodel. And it will need to remodel constantly for the rest of the life of our patient. We know this 140 years now from Julius Wolff. We load the implant, so we apply forces to the bone. And so this bone will need to remodel, become stronger, and resist to this sort of loading. Our message is that we need to try to create the high quality of bone, the highest quality we can create, using the best materials so that this bone will be able to turn over and function normally. That's why we can use xenografts, but we have to understand that those particles of the bovine xenograft, because are a conductive, non-resorbable scaffold, will stay there forever, having an impact on the quality of the bone. When I use synthetics, the particles will break down, they dissolve, and they will give place to high quality, large amounts of new bone. with our trephine biopsies, we can do very high quality of histology also, and we use the best labs. These are some very nice histologies we have done at the University of Heidelberg and in Minnesota University in USA. So our findings, our histological findings, are also the same like other studies. We have a very good systematic review about clinical studies and about the bone regeneration in socket grafting procedure with different grafting materials. This is a paper published 5 years ago, and the results of the systematic reviews are the same with our results. And what we find is that when we use those synthetic materials constantly in human biopsies, we get 35 to 50% new bone in around 3 months. And at this time point, at 3 months, we have around 8 to 13, 14% of residual material. So our findings from our studies are fully in the same with the systematic reviews. Let's see what we can see here. So I take my trephine, and this is the tissue I harvest. And when we place this trephine with the bone into resin, then we can cut the whole trephine with the bone with a sharp knife and place this under the microscope. So we see with this staining the new bone, which is red. We can see the dark magenta, how nicely we can visualize the osteoid. So here the dark magenta are areas of osteoid. It's new bone that it is not mineralized yet. And gray, we can stain here the breaking down particles of the bone grafting material. The most important thing when we use such kind of materials is that we want those materials to dissolve. So chemically, when we implant the bone graft into the human tissue, after a few weeks, the particles, as we can see in those very nice histological pictures, they start to dissolve, they break down. And this is important because when the synthetic, the calcium phosphate, breaks down, it is releasing ions of calcium and phosphate. And this calcium and phosphate that it is released into the fluids in the surgical area, it is triggering, it is enhancing the new bone regeneration. So when the synthetic breaks down, it's not just it's serving as an osteoconductive scaffold, but at the same time, dynamically, it is inducing new bone formation because it is dissolving. Also, when it is dissolving, it means that it gives space for more porosity. And as the porosity is getting better, we have new blood vessels, new cells, and new bone formation. Here we can see the red, the new bone. We can see at the periphery, the islands of new dark magenta here, the osteoid. We can see very nicely all the osteoblasts, and we can see the gray, which are the particles of the bone graft that it's breaking down. This is a silicate beta-tricalcium phosphate power bone. And look here, those very beautiful pictures, how the material is dissolving, and the red and the osteoid is forming in contact and from the inside of the dissolving bone graft material. The same here with different synthetic resorbable materials. On the left side, we have a material beta-tricalcium phosphate with calcium sulfate. This is ethos. This is the particle of the material. It is dissolving, it's breaking down, and as it is breaking down, we can see those lines, those red lines inside the material. It is the porosity that is being created inside the particle of the material. And in this porosity, and also because it is inductive, we have much new bone. So you see the bone that is being created inside the structure of the particle of the graft and in contact with the surface of the bone graft. This is the new bone, this is the osteoid, all those dark dots here are the osteoblasts. And in this picture, we have a different, again, synthetic resorbable. This is EasyGraft Classic. It is beta-tricalcium phosphate with PLGA. So the beta TCP here is covered with a lactide plastic to enhance the mechanical properties. Again, the materials, the synthetics, they work the same way. We can see this is the particle. It is dissolving. You can see how beautifully the image shows the dissolution of the particle. And as it is breaking down, all the osteoblasts, they form osteoid, a new bone, absolutely in contact to the surface of the bone grafting material. So we're talking about a dynamic osteoinductive reaction between the particles of the synthetic graft and the host. The particles, they dissolve and much new bone and osteoid is creating in contact to those particles. That's why they give us very good bone in a very predictable, effective, and fast way. Clinically, what we are doing clinically, many times, like in this case, we cannot place an implant at this time of the extraction because of, most of the times, because of the anatomy of the extraction socket. So let's say in this molar, we have a type C extraction socket. It was a very difficult extraction. That's why I needed to raise a small flap. And as we can see here, there was no septal bone here at all. There was just a big defect. So it was almost impossible to place an implant and get some good primary stability in case I wanted to place an implant. So my only choice is to try to limit the resorption and to try fast to regenerate very good quality bone in order to place an implant after around 3 to 4 months. I can leave it to heal spontaneously, but I feel such a defect with a very thin buccal bone here, if I will not help it with a bone grafting material, I'm afraid that it will collapse very quickly in a few months. So in this case, what I need to do? The first, of course, thing I need to pay attention is to do a minimally invasive atraumatic extraction. So in this way, I will try to preserve as much bone I can, and I try not to damage the surrounding hard and soft tissues. After that, I need to clean it thoroughly. I have to remove any granulation tissue, any soft tissue from inside the socket. When I finish and do this, now I use my bone grafting material. In this case, I selected to use a synthetic silicate beta-tricalcium phosphate paste. It's preloaded in a syringe, so I inject this paste directly into my clean socket. Then I reposition my flap and I try not to advance too much the flap. I don't want to get primary closure, because if I push more the flap to close and protect the graft, then I will ruin all the architecture of the soft tissues. In such cases of bone grafting, I prefer to get secondary intention healing, so I'm not advancing the flap. Again, I have to point out that if we advance the flap more, then we will take all this non-keratinized pink tissue from the buccal side and push it more to the cervical level here. So we will disturb and we will ruin the vestibule and the topography of the soft tissues. The best idea is to try to leave it open, to let it to heal by secondary intention. And in this way, we will get here a good amount of newly formed keratinized soft tissues. So what we get here using such a technique, such a material, we limit the collapse of the site. Of course, after 4 months, there is a kind of resorption. We expect this, but the site has not collapsed completely. And also I have here some new good quality soft tissues that this is going to help me a lot during the next stages. This is what happens radiologically. This is immediately after placing my synthetic beta-tricalcium phosphate paste. We can see that after a month, it starts remodeling. So the graft dissolves. That's why it looks less radiopaque. And at the same time, we have the formation of osteoid, which is not very radiopaque. That's why at the first stages, it looks like the density of the area is not very good. But when it starts getting more mineralized, the area, we can see here after 4 months how nicely we have regenerated the hard tissues in this very big socket. This is after 4 months. It's time now to re-enter. I open again my flap, and I'm very happy to see that all this big, huge round defect now is filled with hard tissue. So I start doing my drilling to place my implant, and we can observe here that at the beginning, when I removed the tooth, all this area was a big gap. I used my synthetic beta TCP paste, and now after 4 months, look, at least macroscopically, how nice hard tissue I have now to place my implant. I place my implant, and here I used a Bioner 5 to 8.5 millimeters implant, and the anatomy of the threads plus the quality of the new tissue that I got here, they allowed me to place the implant at the correct three-dimensional positioning. And not only that, I got also a very good initial stability. It is a molar. I'm not interested to place a tooth immediately, but what I can do, and the best protocols we are working on right now, is to use a customized anatomical healing abutment at the time of implant placement. So I regenerated high quality bone using my synthetic bone grafting material. I placed my implant into a correct 3D positioning, and the ideal thing I can do right now is to create a customized anatomical healing abutment, fit the abutment immediately onto the implant, and just suture and reposition the soft tissues around the customized anatomical healing abutment and let it heal. So by doing that, in one surgery, I place the implant, I place the abutment, and you can see after 3 months longer, everything is ready. I just remove my abutment, and we have managed in quite a challenging but everyday case to regenerate very good bone, to place an implant, and to manage to reconstruct in an adequate way the topography of the soft tissues. Now we just need to take a good impression, analog or digital impression, send it to the lab, and the lab now can follow the anatomy that we created with our anatomical healing abutment, and using CAD/CAM technology, we can get a customized prosthetic titanium abutment, a milled abutment. On this abutment, we fit a CAD/CAM zirconia crown with a layering of porcelain, and we can get a very adequate, successful result with very good long-term prognosis. Again, this is what we are doing every day. A difficult extraction that will lead to a big extraction defect. I grafted using silicate beta-tricalcium phosphate paste. After 4 months, I get very good quality of new bone. For my studies, I can get my trefine to see the histology I showed to you earlier. Placing the implant with our anatomical customized abutment, and we get a very good result that complies with all the aesthetical, functional, and mechanical properties. This is a slide that's showing all the steps, the synthetic paste, the grafting, and we can see how the defect was very nicely regenerated. We have very good bone, and we place the implant at the correct positioning. And from the occlusal view, these are again the steps, the socket grafting, the healing, and it's very nice to see the use of the customized abutment, how it can, without using any soft tissue grafting, how it can help us to reconstruct the architecture of the soft tissues. So from here to go there in a simple surgical step. What happens with socket grafting and synthetic bone grafting materials? Because those materials are quite stable when we place them, sometimes they're like a paste that when we place it and condense it into the defect, it gets hard. So because the material has self-hardening characteristics, we can sometimes leave it exposed. So we leave it exposed in the oral cavity after the socket grafting because we want to let the soft tissues regenerate. Like in this case, I remove this upper molar. Of course, it's essential to remove it in a minimally invasive way without damaging the surrounding tissues. And again here, like we see many times, when we remove a difficult tooth, like a 3-rooted molar, we get a big defect in this area. When I graft it, like here using Fortos Vital, beta-TCP calcium sulfate, I just place a collagen sponge on top, an 8 cross-mattress monofilament suture, and I let it open. Of course, there is a risk, something to go wrong, something mechanically to give us trouble so we can lose some kind of material during the first days, during the first stages of healing. But if the patient is careful and will not brush the area or will not eat something hard, then we see the secondary intention healing. What is happening? What is happening is that the epithelium likes biocompatible surfaces. So those synthetic materials are so biocompatible that the epithelium will never grow inside the material. It's the same like if we have just our blood clot, the epithelium will migrate over the blood clot. The same exactly happens here. So in this case, we took pictures almost every day after the surgery, and we can see 1, 2, 3, 4, 5, 6, 7 days. We see that every day the material is hard, it's still in place, it's a biocompatible scaffold. And what happens now? The body creates a thin layer of connective tissue over the material, not inside the material. The layer of connective tissue is created on the surface of the material. This is the secondary tension healing. This is how the body heals the soft tissues over a grafted site. Now that we have the connective tissue, we have now new cells, new layers of epithelial cells that they migrate from the periphery, and day by day they proliferate and they try to bridge this gap. They try to cover completely the connective tissue and the underlying bone grafting material. So you can see here how it looks, how we can visualize the new cells of epithelial cells. They move every day, they move around 1 millimeter to close the gap. It gets thicker, the gap becomes smaller, and depending, of course, of the physiology and depending of the size of the area, we need some time. But what happens at the end is that the socket grafted area is fully covered by newly formed keratinized epithelium. These are the big benefits of secondary intention healing. That's why I try not to raise a flap and cover my socket grafted areas, because I will not destroy the anatomy buccally, and I will let the body to cover the graft with new soft tissues, and at the same time inside to give me good quality of new bone. This is the concept of socket grafting. We use resorbable synthetics, and at the same time we try not to close for primary closure the gap. This is what we are doing. In other clinical scenarios, we also use resorbable synthetics, like when we want to do some kind of immediate placement. Like in this case, we have this non-restorable central incisor. We have to remove the tooth. And in this case, I used the Southern Inverta implant. This is the new design of Southern Inverta implants designed by Stephen Chu. So they have two unique properties. One is the anatomy of the implant. It has a wider middle part. That part will give me very good initial stability. It has a more narrow neck, so I will have more bone at the cervical level. And it has a platform with a 12 degrees correction. So although I need to place the implant with a buccal inclination, the platform corrects this inclination with 12 degrees. So as you can see, my cover screw will go palatally. This is the initial situation. We have to remove this tooth, and we have to do the best to give back a new tooth with a very good aesthetic and biological result. Again, we have to be very careful to remove the tooth without damaging the soft and hard tissues. We have to do a very good clean extraction and then thoroughly clean and rinse the bone inside the socket. After that, we have to be careful to do our drilling so that we'll place the implant inside good bone and inside the prosthetic envelope to do a correct prosthesis. This is the pilot drilling, and this is the pin that I used to verify the position and the angulation. Now I place my Inverta coaxis Southern implant. We can see that the implant is positioned, and this unique platform will allow me to have an access hole at the palatal aspect. This is the jumping gap. So I have here a thin layer of bone, and I need to assist this area in order to get good bone, very good quality bone, to give me good integration with the implant. And at the same time, of course, I need to keep the volume. A very good option would be to use a xenograft, although we constantly like to use synthetics, even in such cases that we are really focused also on aesthetics. Absorbable synthetics, osteoinductive synthetics, can give us the same results. So what we are doing is that we prepare our paste. This is beta-TCP with calcium sulfate. We fill the whole area. So we do buccally and around the implant a dual zone bone grafting with the synthetic grafting material. Now we have to prepare our provisional restoration. And by doing this, a dual zone grafting, meaning that we fill all the space in between the implant and the buccal bone, and we fill also the space where we want to create new soft tissue with the bone graft. This is the dual zone grafting concept. We get an adequate, very good result after 3 months that I removed my provisional restoration. And now we can go to the lab and make a high quality aesthetic new crown. And you can see the topography of the soft tissues, and we get a very good result. We see here the X-ray immediately after loading. And this is a year after. You can see that because we place and we load the implant, this loading activates biomechanically the new bone. Here, buccally, this is the new bone that we created with the synthetic. And the activation of the new bone, because of the occlusal loading of the implant, biomechanically, the bone will remodel and it will keep the volume as long as the tooth is in place and the implant is biomechanically activated. That's why even in such cases, we are not afraid, we are not reluctant to use resorbable synthetics instead of a xenograft, and we get almost the same or sometimes even better aesthetic and biological results. A different scenario, again, immediate placement. I will show to you again this kind of dual zone grafting with synthetics. We have a patient, he likes to grind his teeth. He also maybe ate something hard, so we have this vertical crown and root fracture of the first premolar. This is the tooth. It's completely broken. We cannot save it. It's not really inflamed. We don't have an acute infection. So we'll try to remove the tooth and place an implant, if this is possible. I started with my extraction, a clean extraction. Then I have to debride the site from all the soft tissue. Any granulation tissue has to go away. And here we see the crack line, how this tooth broke completely. There's no way that we can save this tooth. And this is the fracture line. And we can see this occlusally. We can see how the tooth broke and the anatomy of the tooth. Now we want to place our implant. And again, I have to point out that the most important thing maybe is to place the implant at the precise correct 3D positioning. Now that the implant is placement correctly in this direction and in this direction and at the correct depth, around it, I need to create new bone. I need to support the tissues. I need to keep the volume, and I need to help the tissues to recreate new bone around the implant and new soft tissues around the contour of my future crown. Dual zone grafting. Again, here I use the synthetic granulate silicate beta-tricalcium phosphate to fill all the spaces into the bone zone and into the soft tissue zone. As I said, dual zone concept. And what is very important now is to protect this bone graft into the bone and soft tissue zone. And the best way to cover this and guide the healing is again to use a customized anatomical healing abutment. So this is a stock abutment. It's not good enough. It's not enough to close and protect the space and to guide the healing. We need a customized anatomical abutment. And this customized anatomical abutment, as we can see, has the proper anatomy at the cervical aspect. So a customized anatomical abutment made from a composite can follow in a very good way the anatomy of the tooth that we just removed. So that's what we are doing. We are fabricating a correct, customized anatomical abutment. We place our implant, we do our grafting, and we fit the abutment. We install the anatomical abutment onto the implant. So it's the perfect prosthetic seal for our implant and our underlying bone graft. And it's not just a seal, it's the perfect prosthetic device, the perfect guide to give us the correct anatomy of the soft tissue healing, because we need the correct emergence profile that will have all the space, all the anatomy for the connective tissue zone, the junctional epithelium zone, and the plaque control zone around the abutment, meaning around the future crown. Also, this can help me understand how deep I have to place my implants. So in general, I try to follow the 4 millimeter rule, meaning that I will need 4 millimeters from the platform of the implant to the zenith of the soft tissues, meaning the contour of the future crown. And I will need 4 millimeters of space because that's what the biological width needs for the connective tissue, the junctional epithelium, and the plaque control zone. 4 millimeters. That's how deep, in most of the cases, we have to place the implant, 4 millimeters from the soft tissue zenith to the implant platform. Now just I placed a horizontal mattress to stabilize the soft tissues. And now I need very good soft tissue healing. I need this area to heal in an excellent way, very fast, with no infection. For this reason, we are using some oral gels. I used to use gels that they contain chlorhexidine. I don't use chlorhexidine anymore because it has many side effects and problems. It can also cause even allergic reactions. So what I'm using is gels that they release oxygen. I use them during the surgery. I give them to the patients to use it every day, 3-4 times a day, to achieve excellent soft tissue healing. Because like in this case, we need all those areas to give me a very quick and excellent healing of the soft tissues. So we need to accelerate the reepithelialization, and we need to control the bacteria to reduce any inflammation and any risk of infection. I use my Blue M oxygen releasing gel for those reasons. The patient can use it every day. There are no side effects, and the oxygen will help me from here to get, after 10 days, an excellent soft tissue maturation and healing. And we continue doing the same, and we can see that just by waiting and with the use of the oxygen gel, how perfectly the soft tissues mature and they regenerate around the topography of our healing abutment. Now it's time to remove this healing abutment. For the first time after 3 months, the patient comes back and we remove the abutment now for the first time, and everything is ready. Doing those concepts, following those very simple steps, we have in one go done everything. We have removed the tooth, we have placed the implant, we have done dual zone grafting, and we have conditioned and reconstructed the topography of the soft tissues. Here it is. We can still have this popcorn effect because we used granulate synthetic material, and we did dual zone grafting. On purpose, we placed the bone graft also into the space where we need new soft tissue. So it's of course very logical to see this popcorn effect. And this is another reason why I like to use resorbable synthetics, because I know that after a few months, those particles will be totally replaced by connective tissue. And by doing this, we kept the volume, we kept the anatomy. We can see the morphology here. The topography is excellent. Using simple methods like this one, extraction, implant placement, dual zone grafting, anatomical healing abutment. This is a cervical healing abutment, and everything is ready to take an impression, fabricate a customized crown, a customized CAD-CAM zirconia crown fitted onto a milled CAD-CAM titanium abutment. And you can see how nicely we have created the emergence profile and the cervical profile for our case. This is immediately after fitting the crown. So we try, and I suggest to be less invasive during our everyday practice, to use synthetic materials, customized abutments, minimally invasive protocols to get predictable and successful results. All this is also published, and I will give you all the links to download the papers, how you can apply such methods in your everyday practice. We do now more studies, we do volumetric changes and measurements to see what we get with the soft tissue reconstruction and horizontal expansion of the soft tissue using anatomical abutments, because there are very big benefits with those cervical anatomical abutments. This is what we get when we use a custom stock, when we use a stock healing abutment here. We don't get soft tissue expansion, we don't get the perfect emergence and cervical profile. The opposite, when we use a cervical anatomical abutment, we get soft tissue expansion, soft tissue reconstruction. Look at the quality and the thickness and the amount of connective tissue and soft tissue here. And not only that, we have a perfect soft tissue profile. More cases, oral surgery cases. Again, the same, when we need to do something to promote the healing. Cases we have such cystic lesions. Here we had a patient that had this dentigerous cyst. It was a bit neglected, so it became a bit bigger. We had also to remove this wisdom tooth. We were a bit lucky that the tooth was dispositioned into an area where it was far away from the lower border of the mandible, so it was quite safe at the same time to remove the cyst and the tooth. You can see the erosion of the bone lingually. So in such a case, it's not a very difficult oral surgery case. but it's not a child. So it's a 40-year-old patient. He doesn't have the best healing capacity that we could expect, let's say, from a adolescent or a child. So we need this to heal fast, and we need this to heal with high quality new vital bone. So we will reconstruct the architecture that is lost there, because you can see how the cyst has expanded the bone. It's not a normal architecture lingually. We have all this defect. The nerve is here, so luckily it's protected by a thin layer of bone. I want to give back to my patient vital bone like it was before the development of the cyst. Good surgery. I try to be, even in such cases, as minimally invasive as I can. I always do only buccal flaps. I never go lingually for my flap. I try to stay away from the lingual nerve. First of all, I do a small bone removal. I visualize the impacted tooth. I cut it into many pieces. I don't want to apply any pressure on the bone in such cases. So the tooth is removed. Now I take my instruments and I go down here to mobilize the cyst. We are lucky in such cases because those cysts have a very thick lining, so it's quite quick and easy to remove them. Of course, the lab verifies the initial histology that we have taken before the surgery. It is the whole area of the cyst is a dentigerous benign cyst with no risk of recurrence. And now that everything is clean, I need to promote very good quality of healing. Again, I will use synthetic bone grafting materials, resorbable materials to get high quality vital bone. For the defect, it was more easy for me in the syringe to use a preloaded silicate synthetic paste. So with the paste, I injected the defect of where I removed the tooth, the impacted tooth, and all the big defect of the cyst. It was much easier for me to use a loose granulate, a synthetic granulate. So at the bottom, close to the nerve, I placed some collagen close to the nerve, and on top, I filled all the big space with granulate silicate beta TCP. And why I do this? I do this to have the best healing, to have good bone, because we need to, not just to reconstruct the bone, we need to save the second molar. This is the main objective. We need to have here very good reconstruction of hard tissues so that this tooth can stay in the mouth for many more years. This is immediately after the surgery. Again, after such surgeries, on the surgical wound lines and over the stitches, I use every day this oxygen releasing gel. I give it to the patient to use it every day, because the oxygen blue M gel very nicely will enhance and accelerate the soft tissue healing, and also it will control the bacteria that tend to accumulate on the stitches. Also, if we are minimally invasive, if we use biocompatible synthetic materials, sometimes we have less post-surgical inflammation. So you can see even such a surgery, this is after 1 and 2 days, and then the swelling starts to subside after 7 days. Even in such a case, we have minimal residual swelling. And this is our objective, after 6 months, to have no periodontal pockets behind the 7, to have new bone, so we can see this defect, how it was regenerated, and not only we have new bone still remodeling there, but also we reconstructed and we brought back the anatomy of the mandible. So that was before. This 7 now was in big risk, but you can see now that we can now proceed, make a new restoration. The dentist will proceed to do a new restoration or whatever else needs. But the most important is that the tooth now has bone behind it. We have new ligament, because also the ligament is regenerating. We know this from periodontics. And we did the best we could for this patient. Same topic when we remove everyday easier cases of third molars. And the big problem is that although we don't have complications when we are good surgeons and we know how to remove wisdom teeth, but the main complication that then becomes a problem of the periodontists and not the oral surgeons, because oral surgeons don't tend to follow up the cases. So the cases, they end up to the dentist or the periodontist because many times we have residual periodontic problems at the distal aspect of the root of the 7. So because many times we're a bit reluctant to remove wisdom teeth if they don't have severe symptoms, but what happens is that if the anatomy is not very favorable, we get a chronic inflammation behind the 7. So what that does mean? It means that we have a perio problem behind the 7. If we remove the tooth and we clean it and we don't graft it in adult patients, then we will not get a very good healing. Here I did this case, the patient refused to have any bone grafting. I did my best. I did a minimally invasive surgery. I cleaned this area mechanically perfectly, but still after a year, you see that the bone is down there and we have a big pocket. We can have sensitivity, we can have mobility, and most importantly, if the pocket here expands and involves the furcation, then this tooth will have a very bad prognosis. So what we know is that in adult patients, in patients that don't have a very good healing potential like children and adolescents, and with cases like this, we need to do a bone regeneration technique when we remove the 3rd molar. So what we try to do to get better results. Like in this case, this is a 50-year-old patient, neglected, the wisdom tooth was neglected. She came to the office because in pain, suppuration, inflammation. So I check with my probe and all the probe goes deep behind the 7. I take a small X-ray, you can see all the big problem that the impacted 3rd molar gave us. And we do the scan and we visualize the extent of the problem. There is no bone at all behind the distal aspect of the root of the 7. So let's see what we can do if we can clean this and if we can save the 2nd molar. And the only way to do this is, first of all, to deal with the acute infection. So here I rinse the site with oxygen-releasing blue M fluid. And by giving antibiotics and by irrigating the area, after 2 weeks, we have an area here that has not acute infection. So it's time now to do our surgery. We open our flap. You can see that there was some bone here, although the very big lesion behind the 7, I removed into many pieces the wisdom tooth. And we get now this localized but very big bone defect. First important step is to clean all the soft tissue behind the 7 to remove all the cystic lesion. And then when everything is clean and dry, to graft it with a synthetic absorbable osteoinductive material. If the surgery goes well and the healing is with no complications, this is our objective, to have a very good healing after 6 months, 1 year, 2 years. So you see that we have a good amount for such a case of keratinized tissues, especially here behind the 7. And this is the essential, to have no residual pathology at the distal aspect of the 7. This is the best we can do with wisdom teeth surgery, not just to do a good surgery to remove the tooth, but we have to keep in mind to regenerate the bone in order not to have long-term problems with the 2nd molar. So it took me 1 hour and 20 minutes. this is what I want to share with you briefly from our experience in the last 20 years with synthetics. We believe that synthetics are the future for bone grafting reconstruction, also for dentistry, not just for orthopedics. Of course, every material has advantages and disadvantages, specific indications, but in many cases, like the cases I showed to you, I think that resorbable novel synthetics have a very good place and give us very good results. This is my website, my email, and my Facebook address. You can find the papers I mentioned. You can send me any questions you need, and I would like to thank